Thank you, Rina, and I hope next time I'm there in person. And thank you for this opportunity, Indo-US Bridging Rare Summit, to discuss the aspect or the perspective from the US side. And Dr. Cabra, thank you so much for that background here, because I'm going to take a little bit different approach with the care pathways in the US. I am an assistant professor in the Division of Pediatric Blood and Marrow Transplant and Cellular Therapies at University of Minnesota. And I primarily focus on transplant, the stem cell transplant and gene therapy for rare diseases, which include hemoglobinopathies here as well, which always has been interesting because during the medical training in India, hemoglobinopathies were so common that it was never in the realm of rare diseases. And as we heard this morning about the criteria for rare diseases, it is interesting that both sickle cell and thalassemia are quite under the consideration for rare diseases here. I also direct the Comprehensive Adrenoleukodystrophy Clinic, which is one of the diseases I'll be talking about today at University of Minnesota. And I also lead some of the gene therapy trials for hemoglobinopathies and rare diseases here. So the journey has been quite interesting, actually. I'm in Minnesota now, but where I really started was in the Run of Kutch. So from desert to snow-cold Minnesota, the change in latitude has helped me learn and understand a lot in both the places. So I feel myself definitely being in that privileged spot where I'm at a center of excellence for rare diseases at University of Minnesota, where the first pediatric stem cell transplant was done way back in 1968 by Dr. Robert Good. And since then, University of Minnesota has pioneered the transplants for immunodeficiencies, inherited metabolic disorders, various bone marrow failure syndrome. We heard a very little bit about epidermolysis bullosa that Dr. Thangraj mentioned in his talk. We have done transplants for that, and there are cellular therapies for that fatal disorder as well. And then there is a whole spectrum of other malignant and non-malignant disorders for which stem cell transplant is needed. The ones that I have highlighted, I'll be focusing more on that in this discussion. So again, we have a long history of transplant for rare diseases here at University of Minnesota. We did one of the first transplants for mucopolysaccharidosis. The first one for Hurler syndrome was done in UK, and the second one was done over here. But not just in the mucopolysaccharidosis realm, we have quite a few disorders where we did early transplants. And it is the largest center for transplant for inherited metabolic disorders in the US. Not only have we done the transplants, we have also shown that it has significantly improved the survival and functional outcomes in these disorders. It is also the leading institute for novel therapies for inherited metabolic disorders, and not just the gene therapies, but other cellular therapies that are coming in this realm as well. So these are some of the rare diseases that we as transplanters treat here at University of Minnesota. And again, for mucopolysaccharidosis, I have just limited to Hurler and some of the Hunter patients who undergo transplant. But there are other lysosomal storage disorders where transplant is indicated and is the standard of care. Other than that, there are leukodystrophies and some of the peroxisomal storage disorder, just like adrenoleukodystrophy, where we are the largest center for the treatment for cerebral ALD. And then there is congenital osteopetrosis, for which, as the team might know, that Dr. Orchard is an international expert for this disease. And again, it is not, I do not take any credit for all of these transplants. There is a whole team, and Dr. Paul Orchard, who leads this team, has been a pioneer in most of these disorders. So care pathways in the US is very interesting, and actually for quite a few of these rare disorders, we have newborn screening here. So there is a recommended universal screening panel, or the RUSP, that looks into these different disorders and puts forth a national guideline. And there are about 20 plus core disorders, and then there are secondary disorders, which are like about 50 plus. But it is not a federal mandate, actually, that you have to screen for all of these disorders. It is up to the states eventually, or the State Department of Health, to implement this national guideline. And depending on the states, some states have a policy to adopt whatever RUSP recommends, and other states actually have their internal mechanism. It's not that every single rare disorder gets onto this newborn screening panel. There are certain criteria for including them, and there's an intense discussion that goes on behind the scenes. There needs to be a validated diagnostic test. There needs to be an approved treatment. And also, you need to show that the early diagnosis does impact the outcome. So one of this rare disorders is X-linked adrenoleukodystrophy, where it's a paroxysmal X-linked disorder with a frequency of about 1 in 17 to 20,000 boys born in the US. The defect primarily is in this gene called ABCD1, which codes for the ALD protein, which is a transport protein that shuttles very long chain fatty acids into the mitochondria. A defect in this transport protein leads to accumulation of these very long chain fatty acids. And if you can measure that in the plasma at an elevated level, that is pretty much diagnostic in this disorder. Newborn screening in this disorder became active in the United States in 2013, and it was strong advocacy from family foundations and ALD Alliance being the leader in that. The first state to do that was New York in 2013, and since then, like in 10 years, there are 40 plus states who have adopted newborn screening for this disorder. XALD is in itself is quite a challenging disease, and where as a transplanters we come into picture is for the cerebral form of the disease, which involves the brain, and I'll show you in the next slide the image of what that disease looks like. What transplant has shown in this disorder is that for cerebral ALD, it can actually stop the progression of the disease. It cannot reverse it, but it can definitely stop the progression, especially in the early stages. So this is what an MRI looks like for a child with progressive cerebral ALD. And as you can see, the white areas that are pointed over here, they are the areas of defect, and it is like a wildfire that is spreading. So what you want to do is that you want to contain this disease as early as possible to minimize the neurological deficits and improve survival. Before the newborn screening, the challenge with this disease was that the diagnosis was usually in a later stage. The only cases where we would diagnose these little kids was actually if they were adrenally insufficient or in a crisis, or there was like early neurological symptoms, or there was a family history of this disorder. Most of the cases, as like I hear from India as well, actually, most of the cases are unfortunately advanced, and unfortunately at that stage, even bone marrow transplant doesn't work. So lack of treatment effectiveness is a big problem, and this disease has a high morbidity and mortality. So after the newborn screening, actually, the care pathway in the US is once the patient is identified on the newborn screening panel, the notification goes to the primary care team or the geneticist, and then they talk to the family and do the confirmatory testing. And eventually the patient is plugged into a comprehensive ALD clinic. Now, at University of Minnesota, we have built this comprehensive care clinic, which is a medical home for these patients and families. And it is not just that patient who was tested positive on the newborn screen. There is a wide cascade effect, actually, because it's an X-linked disease, and our genetic counselor sits down with the family and plots the pedigree and tries to identify all the potential cases. There have been cases where the baby brother was picked up on newborn screen, and there was a child in the high risk, another child in the high risk age group, a sibling who was identified just because of that positive newborn screen in the sibling. These patients were like still having the early disease, and they underwent a successful bone marrow transplant, and their disease has been stopped, and they're doing really well. So there is not just the patient effect, but there is a much broader effect of these programs. For the patients or the babies identified by newborn screen, we have a regular monitoring and surveillance plan, and the whole goal is to identify both the adrenal insufficiency and cerebral ALD at an early stage. It also provides the opportunity to counsel the families and discuss about the potential treatment options, and it has surely helped us to show that there is definitely improved survival, improved survival as well as the functional outcomes. As Dr. Cabra also mentioned, that there's also the opportunity to do research and develop actually registries along with this. So along with this comprehensive ALD clinic, we also developed an ALD National Registry and Biobank, which is actually a whole remote platform where we do online surveys. Like we have a team that does medical data abstraction, and we also get biospecimen banking, again, which we actually do remotely as well. The other disease that I want to touch in the next few minutes is sickle cell, which is definitely close to heart. So we live in this upper Midwest area where, interestingly, when I ventured into the sickle cell zone, I was told that sickle cell patients don't live in cold climates. So there's nothing in the upper Midwest area that you are treating. I didn't believe that because we do have a comprehensive sickle cell program in Minneapolis. Though it is cold, it is not necessary that you don't see families there. We do have a good chunk of West African immigrants actually who have settled in these upper Midwest areas, and there is definitely sickle cell in a lot of their second generation kids. So when I ventured into this territory, I noticed that there were different centers who were scattered across upper Midwest, and they were taking care of some sickle cell patients. But again, when the numbers are small, as we know very well in rare diseases, the approach and the resources that are there are limited as well. So we went on a mission to integrate all of these centers and identify the challenges that these families were facing. So I come from the curative therapy aspect of the sickle cell, where we offer transplant and gene therapies for these children. And we noticed that the referral actually that was made to the transplant center was quite late in the disease course. They already had an organ damage. There was a lot of issues that these children came up with when they were meeting our team for the first time. So what we did was we reshaped this model to target sickle cell cure. I know cure is a little controversial word in this side of the hemisphere, but we actually use a different approach here where community engagement was the key. So I don't know if Teresa is there, Ginger is there, but I work very closely with Ray Blaylark here, who runs the Minnesota Sickle Cell Foundation, and we partnered with the advocacy organization. We partnered with the sickle cell centers who were taking care of any number of sickle cell patients. We also partnered with the patients and the other community members who were actually stakeholder in this. And what it turned out to be in the last 3 years was that it actually helped us do a lot of these initiatives actually more aggressively and more upfront to help these patients and these families understand the true effect of these curative therapies. Again, so these are some of the things that we were able to do. HLA typing, we were able to initiate early discussion and education about these curative therapies. We were able to identify some of the issues with the current options and understanding the psychosocial barrier that these families had. We actually developed a consortium across Upper Midwest where we meet once a month virtually, and we discuss about all the potential patients and all the potential issues that our patients are facing, including the fertility preservation. We also address the social barriers. There are like more than 50 people actually who jump onto these calls where social workers, the nurse coordinators, the research people, all of them are here, and we discuss about all the potential options that the patients might have. So what it ended up with is a strong community engagement with a community provider partnership. There are families who are seeking out this education at a much earlier level, and we do feel there is more awareness of the curative options. I cannot show you the numbers. Actually, I'm in an embargo by American Society of Hematology because we are presenting some of this data at American Society of Hematology meeting next month or in December. But we do notice there is much increased number of sickle cell patients undergoing curative therapies, including participation in the clinical trials. Sitting in the upper Midwest, we are actually one of the highest enroller for clinical trials for sickle cell gene therapies. Again, I think it is more from the community participation and identification of these patients. But at the end of it, this all melts down to one big word, that is stakeholders. We all are stakeholders in, be it ALD or be it sickle cell or any other rare disease, and these are the key component that I can visualize on my end, and I'm pretty sure there are quite a few that I'm missing here. But it is not just the patients and families, but all of these, as Dr. Cabra mentioned, the hub model where all of these spokes need to integrate and work together to build this collaborative where we can actually offer the best diagnostic and therapeutic modalities to these rare disease families. And with that, I will acknowledge my team over here, especially Dr. Orchard and Dr. Land, who are the leads for this inherited metabolic disorder transplants that we do over here. But again, it takes a village to do these transplants. I'll also acknowledge and thank Indo-US Rare Disease for this opportunity to present some of the work that we have done. Thank you.